Hi, everyone. This is Dr. Nasir Gami, and thank you for joining me for this podcast episode. I hope we have a few people live today. We started on a different time than I originally had scheduled, but I hope we have some people still here. If you have questions, comments on the live chat, please provide it. So the topic today is treatment-resistant depression, another wrong psychiatric concept. The concept of treatment-resistant depression, or TRD, as people often say, is wrong in a way if the concept of depression that underlies it is wrong. And we've talked about that before in a prior podcast episode on the DSM and how most of DSM is not valid scientifically in terms of being proven to be legitimate diagnoses that exist in the real world of biology or psychology separate from other diagnoses. And we talked about that in relation to major depressive disorder, which is the underlying concept behind treatment-resistant depression. And the idea was that major depressive disorder, quote unquote, or MDD, is not really a valid concept, and that it mixes up many different kinds of depressions so that it's not a disease that exists in the real world, and it's not a scientifically valid concept. If that's true, then perhaps it would not be surprising that the use of so-called antidepressants, things like serotonin reuptake inhibitors, would not be very effective in a condition that's not valid. So the whole concept of treatment-resistant depression is, in a way, just a repetition of the concept that DSM's concept of MDD is not valid. Of course, if something isn't real, if it's not valid, if it doesn't actually exist in the biological or scientific world, then creating a certain medication for a certain receptor isn't going to make a big difference. The problem isn't with the medications, the problem is with the diagnosis. It's not treatment-resistant depression because the medications don't work. It's treatment-ineffective depression because the concept of depression isn't valid enough for medications to work. The concept of treatment resistance in general in medicine is something that we have when you have a class of drugs like, say, antibiotics that are effective drugs most of the time for specific infections for which they work. And there might be a minority of people with those infections that do not respond to the effective drugs. In that scenario, the majority of patients get benefit, a minority do not, and you might call the minority treatment resistant. But if you had a scenario where the majority of people don't respond to a class of drugs, that's not treatment resistance, that's just treatment inefficacy. And what I'm going to describe to you today is how, with so-called MDD, the majority of so-called antidepressants do not work long-term. And so that's not treatment resistance, that's just treatment inefficacy. The whole class just doesn't work well. And actually, though, as I said, I don't think the problem is with these different mechanisms of drugs per se. The problem is that they're being given to an ineffective or invalid concept where their efficacy is really watered down. So let's drill into this a little bit. Of course, the most commonly used class of medications are the SRIs, the serotonin reuptake inhibitors. And treatment resistance is viewed as failing to respond to 2 or 3 trials of an SRI. I'm going to see if I can show you with a slide or two how this plays out with some of the research that's been done, specifically with the largest and most important study in recent years, the so-called STAR-D study, Sequence Treatment Alternatives for Resistant Depression, which was a big NIMH-sponsored study. I'm sure many of you are familiar with it. Paolo, backstage, can you put up the slide there? Thank you. So in STAR-D, what we have is a scenario where patients are initially given citalopram, an open label treatment. And let me see if I can go full screen if this makes it bigger. I'm not sure if that does. Okay. So they get citalopram, an open label treatment, and about half the patients respond. Then they get randomized to something else, another SRI, venlafaxine, or augmentation with bupropion or buspirone, and about 1/3 responds. Then if they don't respond to that, they get switched to a tricyclic antidepressant, which is generally seen as the most effective class of medications we have, or they get augmented with lithium and only about 15% respond. If they don't respond to that, they get monoamine oxidase inhibitors, which along with tricyclics are seen as the most effective, or a combination of venlafaxine and mirtazapine, only 15% response. So what you notice here is you start out with a decent response rate, open labels, not blinded, 50% of people. And then at each step, about half of the response decreases. So 50% becomes 30%, 30% becomes 15%, and it stays there. So what this is telling you is that once you fail a single trial of an antidepressant, you will have only about half the response in the next trial. And after that, you'll have only half the response there. And in the end, after you fail 3 trials, you're at a 15% response. That means 85% likely not to respond. And this is defined as getting half of your symptoms better over 8 weeks. So it's a short-term benefit. Now, if you keep following these people, and one way of looking at this, I should say, is that if you add 50% response to 30% response to 15%, it's about two-thirds or three-quarters of patients respond if they get 3 or 4 different antidepressants. And then typically people call the rest of them treatment resistance, the 1/3 or 1/4 that's left. And then there are all these studies you're hearing about with ketamine and psychedelics and things like that people talk about for those patients. But the truth is that 2/3 acute response is only for 8 weeks. What happens to them after 8 weeks? Well, if you follow those patients for 3-6 months longer, what you'll see on this slide, to focus on the yellow, is that 40% of those initial patients who originally responded relapsed into another depression. And then if they responded later in the second trial or the third trial, 65% relapsed again back into depression within months, even though they stayed on the antidepressant that eventually had made them better for 2 months. So if you add this all up, on the green line, you have the acute response, the 50%, 30% or so that we talked about earlier. You see that response goes down with each trial. But the relapse in those who do respond goes up with each trial. In other words, if you're lucky enough to get better, you're not going to stay better. And so the 2/3 response acutely, which is adding up these guys, is actually only a 1/3 response within 3 to 6 months when you continue following people. So Paula, we can go off the slides now. So the point I'm trying to make is that treatment resistance is not the 1/3 who in the short term don't respond to multiple trials. It's the 2/3 who over 6 months, 9 months don't stay well. Because these patients with depression that we see in practice, the ones who come into the studies, are not people who've been depressed for 2 months. Usually they've been depressed over and over again for years. So the point is not just to get well, the point is to stay well. And the thing that's confusing for people about so-called antidepressants is that, yeah, they can get you well for a couple months. And that happens maybe in 2/3 of people with multiple treatments. But they don't keep you well for 6 months or a year or years or decades in the majority of people, 2/3 or more, according to the STAR-D study. And if you look at the overall maintenance studies done on randomized trials for maintenance treatment of antidepressants and so-called MDD, they show that after about 6 months, there's no benefit. The drugs are better than placebo, but that's only in the first 6 months. The relapses are lower on the antidepressants than placebo in the first 6 months after recovery from a depressive episode. But after 6 months, the rates are the same between antidepressant and placebo. So the proof we have now is that if you have a clinical depressive episode, these antidepressants may help you for a few months, up to 6 months. But after that, they really don't seem to, or at least we don't have clear evidence that they do. And so what's being called treatment resistance is not really people who just don't get well on antidepressants. It's in a minority of people, like 1/3. It's actually the majority of people, 2/3 or more. And they may get well short term, but they relapse long term. The issue is not that they just don't get well and we need something to get them better quicker in a month or a couple of weeks, like with these hallucinogen trials. The issue is we need to get them to stay well once they recover and to not relapse into a new depressive episode 6 months later, a year later, 2 years later. And that's a maintenance type design. And that's not what the pharmaceutical companies are doing. That's not what all these so-called psychedelic studies are doing. They're all looking at 1 month or less. The longer term studies are not double blind and randomized. They need to be. Open label studies don't count. They don't give you evidence regarding efficacy. So that's my general view about treatment-resistant depression, that it actually happens in the majority of people, and that it is a mistaken assessment about the fact that short-term benefit goes away and long-term prevention really isn't there. The difference between symptomatic effect and disease-modifying benefit, as we've always said. Now, I want to remind you why I think this is diagnosis-related rather than related to just the drugs not working, and why I think there's a mistaken emphasis now in drug research on just trying to find a different mechanism and a better mechanism, whether it's NMDA or hallucinogens, and that's the solution. No, the solution is to get our diagnosis valid and to try to get drugs that prevent episodes, not that treat them. So Paolo, if I can get the slide back up, thank you. So to remind you, among the reasons we talked about MDD not being valid is this concept in the development of DSM-3 in 1980, where the old concept of manic depressive illness was divided into two groups, bipolar and unipolar. And this unipolar group was then changed to MDD, major depressive disorder, when other older concepts of depression, like neurotic depression and chronic melancholia, were included with it. We won't get into all the details here. We'll discuss it more in other settings. But the point is that there are these different kinds of depressions, and they've all been lumped into one group, the MDD category. And that's been separated from the bipolar category. And some of it used to be combined. And the combination was viewed as invalid and changed in 1980, because the idea was that the unipolar and bipolar patients had different genetics and different courses of illness, and also different treatments. And now we know they have the same genetics, very similar overlapping genetics, very similar courses of illness, very similar biologies as well, and actually very similar treatments in many cases. So the idea that these are legitimately two different illnesses, unipolar or bipolar, as opposed to one illness, manic depressive illness, I would say is scientifically very questionable, and in fact, invalidated by the research that's been done, the genetic studies for sure. And so we have this invalid concept of MDD where we've combined all these different kinds of depressions. And so when we say someone has a quote unquote major depressive episode, they could have any of these different varieties of depressive states. They could be, for instance, mixed, where they have manic symptoms with their depressive symptoms. They could be melancholic, which is the opposite, where they're really slowed down and anhedonic, whereas the mixed patients are really sped up and excited. They could have neurotic depression, which is much milder with some anxiety, doesn't even have episodes much, and goes away very quickly. They could have chronic depression, which these days seems to be more vascular, and they have MRI abnormalities, and there isn't really episodes. It just continues all the time. You might call, if you don't have any of those, a pure depressive episode. And maybe it's the pure depressive episodes that aren't manic, so they're not mixed, they're not melancholic, they're not vascular, they're episodic, they're not neurotic. Maybe that's the kind that responds well to SRIs, for instance, but any benefit you have there is going to be watered down by all these other types of depression where we have much less depressive episodes. So, for instance, in mixed states, antidepressants don't work very well, and they can cause manic episodes and make people actually worse and even more suicidal. In melancholia, SRIs don't work very well at all, and tricyclics and MAOIs, monoamine oxidase inhibitors, work much better. In vascular depression, we have very little evidence that antidepressants are effective. And in mild neurotic depression, we have very good evidence that antidepressants are equal to placebo. They work, patients get better, but they get just as well with placebo. So the watered down nature of the benefit of the antidepressant over placebo is because of the mixing of all these different kinds of depressive types, some of which respond worse to antidepressants, and a few might respond to them, but the overall effect then gets watered down. So I think the problem is not treatment resistance because of the medications not being good. I think the problem is that our diagnostic concept is messy and invalid, and therefore any single medication intervention with a single mechanism is only going to go so far. Paolo, you can take me off the slides here. Get off the slides and get back to just me. So close the slides up, Paolo. Let me see if I can do it. Okay. So now the last thing I think to say is that the concept of TRD is very much tied up to the overall issues with DSM. And when we're trying to find better medications or use better medications, we should always ask first about the diagnosis. And it's not so much whether the diagnosis is correct in the DSM sense, but whether the DSM diagnosis is valid to begin with. And I think that's where we have a problem. And I'm not noticing any comments or questions in the chat. It may be that that has to do with our timing. Let me remind everyone that you can go to psychiatryletter.com. We'll put the link in on the YouTube site, and you can read more about this topic and other topics on our website. And I go into it in much more detail in our webinars as well. So feel free to go there, as well as in the psychopharmacology textbook, where I've described this in writing in some detail as well. And we'll certainly be coming back to this topic and related topics in future episodes. So I don't see any comments or questions. So I thank you for joining me for this podcast episode, and I'll see you next time.